And all right, you can see my slides?
Yeah.
Excellent. Okay, we'll wait a minute or two for everyone to come in. And we're going to get started. But I see a lot of people coming in.
Yeah, it's standing room only.
Everyone coming in, if you want to introduce yourselves on the chat, tell us where you're from, you can do that. David from Trinidad and Tobago.
Nice.
Maurice, Chicago. Oh, okay.
Australia, Hawaii.
Wow.
Australia. Yes, there it's going too fast. From everywhere. Hello, everyone. Thank you for introducing yourselves. We're so glad you're here with us. All right. 1 minute in, so I'm going to start with the introduction while everyone keeps coming in. So welcome, everyone. I am Dr. Natalia Rosas, and I am the Education and Training Coordinator at the NTG. I want to welcome you to the second webinar in our series, Advancing Dementia Capable Primary Care, Supporting Adults with Intellectual Disabilities. We are pleased to have today Dr. Seth Keller with us to present Diagnosis and Management of Dementia in Adults with IDD. We also have with us Helen Stepowani, who is our project manager for our Special Olympics, which is funded by the Changing Thinking Project, which I will tell you in a little bit, and NTG Chief Operations Officer, Catherine Pierce. Both Helen and Catherine will be monitoring the Q&A box and the chat box. All right? Okay. Before I begin, let me acknowledge our sponsors and partners. We would like to acknowledge that this webinar is part of the NTG's Changing Thinking initiative, which is supported by a grant from the Special Olympics through its Systems Change for Inclusive Health program, which works to improve access to healthcare and reduce disparities for people with intellectual and developmental disabilities. We are also grateful to our webinar partners, the American Academy of Developmental Medicine and Dentistry and the Developmental Disabilities Nurses Association, for their collaboration and for providing the CME and CEU credits that make this educational program available to healthcare professionals across disciplines. Please note, everyone here, all of those that need the CME or CEU credits, you need to attend this webinar live, which means that you're here online with us. And I see Amy raise her hand. If you can write on the chat, or you can send a direct message, that would be great. You can send direct message to Helen and Catherine, and they can help you. All right, so I was saying, if you need CMEs and CEUs, you need to be attending live, which means here online today. This will be recorded, but if you watch the recording, then you cannot get the CME and CEU credits. And you need to watch it in its entirety. All right. A few housekeeping items. This webinar is being recorded, and it will be shared with registrants after the event and also uploaded to YouTube. Participants are muted upon entry. Okay, that's why you can't talk or we can't see you. But if you have any questions, please write it on the chat or the Q&A. We would like, if you have questions for Seth, our presenter today, that you write your questions in the Q&A box, and then at the end of the talk, we will go one by one and answer as many as we can. If you have comments or other things that you want to chat, then you can do it here in the chat. So certificates are not available unless you can get the certificates from these two entities that I told you, but I will tell you more about it at the end, so don't worry about it. I promise. We'll go back to that. Okay. I think mention everything? No, yeah, I think I mentioned everything. All right. So briefly, I want to introduce the Guiding and Improving Dementia Care, or GUIDE model, which is an 8-year national initiative launched in 2024 by the Centers for Medicare and Medicaid Services to improve care for older adults living with dementia. The model strengthens dementia care through care navigation, interdisciplinary care teams, expanded caregiver education, and better access to dementia resources and services. Importantly, GUIDE also creates an opportunity to improve support for adults with intellectual and developmental disabilities who develop dementia, which is a population that has often been underserved in traditional dementia care systems. And so associated with this, we have our Changing Thinking project, which is a national initiative led by the NTG and funded by the Special Olympics. And the idea of this project is to support GUIDE providers in better serving adults with intellectual disabilities and dementia by offering free training for caregiver navigators, specialized resources, technical assistance to GUIDE sites, and guidance for families and community organizations. So its goal is to help providers recognize dementia earlier and deliver more person-centered dementia-capable care for adults with intellectual disabilities. You have there QR codes to the NTG website that has, and here are the codes, sorry. The NTG website that has a lot of resources. There is a free navigator training. If you are a guide navigator, there's free training, there's guide advisories. And you can also download the NTG eDSD, which is also available in several languages. Somebody will also post the links in the chat, but otherwise you can visit our website, which is the NTG or the-ntg.org, and find this that I'm showing you and a lot more. Finally, and before we, almost before we start, if you are not following us, please follow us on your favorite social media platform. We are on Facebook, we are on Instagram, we are on LinkedIn, and we also have a YouTube channel where we post all of these free webinars. So you can subscribe to our channel and you can watch this webinar and past webinars as well. So please, you can use those QR codes. We'll post the links in the chat as well. All right. I see there's a lot going on in the chat. A lot of people talking about CMEs and CEUs. I promise you there at the end of the talk, I will tell you what you need to do to get everything you need. All right. Now, this is maybe a link that you want or a QR code you want to scan if you want to have the slides for today's talk. This is a link to the PDF. You can also, hopefully somebody will post the link in the comments as well if you can't use a QR code, but otherwise I'll leave this up for a few seconds so you can scan it and get those slides. All right. Okay, I'm gonna move on, but I will put the link. There's the link on the chat, okay, for everyone if you missed it. So I get to introduce Dr. Seth Keller. He's an MD. He's board certified neurologist with the Neurology Associates of South Jersey, where he specializes in the evaluation and care of adults with intellectual and developmental disabilities, including those with complex neurologic and aging-related conditions. Dr. Keller is recognized nationally and internationally for his leadership in advancing health equity, dementia care, and interdisciplinary education for people with IDD across the lifespan. And as an example, he has been selected as a Fulbright specialist, and this is an honor that reflects his international leadership in advancing neurologic care and inclusive health systems for individuals with intellectual and developmental disabilities. I'm going to stop sharing, but I'm going to keep talking about Dr. Keller because he's so awesome. and, and he's going
You're
to
so kind. You're so
put up.
kind. You are. Here, can I take over, Natty? Can I jump in and put my...
Yes, you can put your slides.
No, I mean, you're good. I mean, God, Natty, you don't have to... Stop, please, no more.
He is so awesome.
Oh,
Let me tell you a few more things.
God,
He
God.
serves as the executive board of the ARC of Burlington County and the board of the ARC of New
Yes,
Jersey's Mainstream Medical Care Program. He's
yes.
a past president of the American Academy of Developmental Medicine and Dentistry, and he is currently co-president of the NTG. And so, well,
You
we're
got
all
it. You
very
got it.
happy to have you here and learn from you. So
Thank you, Natty. And
thank you for being
I'm
here.
friends and colleagues with you and a lot of people on the call. So I'm honored. And actually, you may not be. I'm actually wearing my T-shirt of the ARC. As you were mentioning, I'm a huge supporter of people in the community, and I'm wearing my ARC of Burlington County. I'm on their executive board, and without my colleagues, I don't know if I have anyone of the ARC here today on the call. But anyway, thank you, Natty. All right, we'll see you at the end. So thank you very much. I mean, I'm really I'm honored. I know that I'm amongst friends. We have a lot of people. It's always cool to see like people roll in from around the world, and it's neat. It's fascinating. It's certainly, as you all know, this is a big issue and a big topical area, not only where I certainly live in New Jersey, but anywhere and everywhere that people with intellectual and developmental disabilities are living longer. And I'm a neurologist, and as a specialist in neurology, I do treat older populations, not just people with IDD specifically, but really those that are 18 till death. And I have a lot of people, certainly with intellectual developmental disabilities, in my private practice here in New Jersey. But I see all people. And my presentation, and if you were on the previous presentation before with Dr. Brian Jacoin, which is really, really super and outstanding, this presentation is basically like a handoff in a way from what Dr. Jacoin was doing about primary care, first visits, early assessment. So this is really a pivot from the work and discussion that Dr. Jacoin was doing. And then my presentation will then also, as we'll talk about at the end, a handoff for our third presentation, which is really more about supports in the community and caregiving and more than I'm doing. But I am a physician, I'm a neurologist. I'm going to be focusing on that aspect. I'm an open book. I don't have any conflicts or disclosures. And as you'll see, at least on some of these slides, QR codes, you're already introduced to QR codes, photographs. And some of these photographs, or if not all of them, are because of my good friend and colleague, Rick Gadati, of positive exposure. So if you have not heard of positive exposure, if you don't know of Rick Gadati, please, 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 if you can just, put your camera up and take a picture of the QR code, that you'll see. It's really visual, the pictures of humanity, of the people that we all care to support in digital and video form, and that's what positive exposure is. And I'm a big fan of Rick Gadati and positive exposure, and I'm on their board. So it's a real pleasure to have these pictures. You may have already gotten this before about what some of the learning objectives are. I'm going to be going through some of the more diagnostic aspects of Down syndrome and those with IDD, about trying to think about how to think about making the diagnosis. I'm going to be looking at issues related to what we'll call pseudo dementia, or those that mimic dementia, and definitely determining the causes of these situations when people present to healthcare providers. And I'm going to be going into a lot more than that. So people with IDD, just to kind of give a sense, and I imagine if you're on this call, you're in the field. So as you're seeing, and I've been around for 35 years practicing medicine for a long, long, long time, and in my lifespan, there's no doubt that people with intellectual developmental disabilities are living longer than ever before, and really comes with living longer is age. I'm going to be 65 years old. Yay, 65 years old this year. So I'm actually seeing the benefits or such, or the changes in me of what aging looks like. And certainly those with intellectual developmental disabilities are living longer. And with that come age-related changes, normal, maybe not normal, and we're going to be speaking about that in some respect. And definitely, as we'll be speaking about, this is not only about people with Down syndrome, and a reason I'm even making a point of it, because issues of dementia related to Alzheimer's disease, it's really thought a lot or spoken a lot about people with Down syndrome. Why? Because of the very, very high prevalence of Alzheimer's disease in people with Down syndrome because of trisomy, the extra chromosome 21. And I'm definitely going to talk about that in some respects. So I'm going to come back to that. Decline is a reality in terms of aging. People who are getting older, whether it's yourself, your family members, your parents, your grandparents, and this will come as no surprise to all of you that as people are getting older, physically, mentally, emotionally, perhaps, they're not the same. And when they're not the same, is it normal aging? Is it a sign of a disease? Is it a sign of a condition? And when they're getting older, what does one do about it? And this really presentation, the way I look at it, I can relate. I mean, I could just sit down and talk about my own personal family issues of my mother that had Parkinson's disease. And my mother had Parkinson's disease in her life. And as she got older, she had declined. And sadly enough, my mom, her name was Mitzi Keller. Sadly enough, when my mother got in her 70s and 80s, she too developed dementia. And so for me, dementia is not only a professional interest for me in my own world, it's very, very personal in terms of how it's affected me. And I'm sure there's a decent percentage of people who are listening today either have family members or know people who've had dementia, even though you might be certainly working in this space. So I think many of these things, these are very common conditions that you personally, professionally, or otherwise have touched upon. Does it matter? Yeah, I mean, it really matters in many respects. One, why it really matters is when there is a decline in functionality, it has an impact upon activities of daily living, the ability for the person to live well and be happy at the activity of daily living. It really matters. And when people have changes and decrements and reduction in their activity of daily living, what does that mean for not only them, of course, but for those that are supporting them? And because this presentation is about Down syndrome, is about people with intellectual and developmental disabilities, most people who we've been referring to have probably to some degree have had lifelong supports based on their level or severity or degree of their intellectual and developmental disability. But as they get older and they're showing sign of decline, they need more. And so, yes, it does matter in that respect. But we need to know it matters because we want to understand why is it happening, and we just can't really quickly blame normal aging because it could be normal aging, but it might be something else. And that really brings up the concept of diagnostic overshadowing. So I could speak all day long about diagnostic overshadowing, but that really is the bias of thinking that the change or decline or changes in the individual are related to their underlying developmental disabilities. Really, rather than thinking, well, maybe there's a disease, maybe there's a condition, maybe there's some kind of impairment. So diagnostic overshadowing is really common. It's really common in many people with a disability or intellectual developmental disability. And if change is happening, what can be done? How can you mitigate? How do you fix? How do you change? Can you cure it? Can you fix it? Can you slow it down? Looking for plans if they're progressing. And then definitely, as I'll be speaking about, and certainly on the third lecture, family support, caregivers, and again, there could be a lot of people on the call today, and this might be relevant to you, but I'm also going to talk about treatment. Testing is going to be very important, as I'll speak about. Our specialists interested in seeing these individuals? Do we send them to a psychiatrist? Do we send them to a mental health provider, a neurologist, therapist, social supports, or all the above? And because of the fact that I'm a specialist, most people that I see have already been referred to me from mostly primary care. So they're really not self-referrals. Most, if not all, people that are seeing me already been seen by other practitioners before me. I wanted to also talk about, as you're seeing on the slide, the NTG EDSD. And as already I mentioned earlier about this one, the early detect and screen for dementia is a tool, an assessment tool, I'll put it that way, of people that are aging with an intellectual developmental disabilities. And we want to basically see whether there's a change, there's a reduction or a loss of functionality in them. And that's what the EDSD is. The early detection screen of dementia is a tool filled out by family members, by caregivers to document that maybe a change from 1 year to the next has changed. It's not diagnosed for dementia. It doesn't say specifically why they're changing. It could even be normal. But once there's a documentation, and this is a formal documentation on a form like this, then that would really then drive the conversation that they need to be evaluated to find out why. So the EDSD, and there's a QR code that we would love for you to look at for those that don't know the EDSD, to how this could be very helpful for you in the community to use this information to drive the conversation as like an early warning sign that something's going on and start looking about why. So there are tools, there are other evaluations that are done specifically to help document that a change like dementia has really happened. And this is a particular slide that talks about a number of different tools that are actually, many of these are actually performed by like a trained psychologist. So individual goes with a psychologist, the psychologist does these questions and queries on them, and they put together the information, and then the feedback is that their change is consistent with a dementia, and these are various tools that are listed here, including the EDSD is on this, and this is something that if you have a specialized psychologist or tester in your area, they might be able to do some of these tools. But I'm only mentioning this particular slide for those that actually are in areas that might have a specialist that could do these tools. In my world, as a neurologist in New Jersey, I can't say per se that I use these tools, but they have been used and they are used, and sometimes they're used in research studies to help more documentation that the changes are really related to a dementia diagnosis. So what is dementia? And I always get this question lots and lots of time. Doctor, you mentioned about dementia, then you're using the word Alzheimer's. What do you mean? It's a little confusing about the two. And I think it's really important to really understand it because sometimes it can be very confusing about what the words really mean. Words do matter. And dementia into itself really is a general term. It's a broad term, and it's inside this umbrella. You can see like the outline of the black umbrella, and that's because it is an umbrella term. It's a broad term that really more or less defines a symptoms or changes that happen to the individual where their thinking, their reasoning, their memory over time, not within a day, not within hours, over time begins to change and get worse. And as that's happening over time, that individual needs more help. And that is basically in many returns or a concept, that's what dementia is, the term of someone declining, needing more help. The other word for dementia is neurocognitive disorders. So what causes dementia? So dementia, again, is just a term that one of the most important things, not only just to say that the person has dementia, it's saying why. What is actually causing the person to change? And that's the elements underneath the umbrella. And to the one that's underneath the umbrella to the far left, it says other dementias. You may not be able to see it, but it has a whole listing of change that can be causing a dementia. Maybe it's something within their blood. Maybe they're exposure to alcohol or drugs. Maybe they've had head injuries. Maybe they already have infections before. Maybe they've had multiple sclerosis. Maybe they have a condition called normal pressure hydrocephalus. And in red, it says depression. And I'm going to be speaking about that a lot because in someone that has pretty significant depression, IDD, Down syndrome, normotypical people, a very significant depression can actually mimic and look exactly like what a dementia is. So it's very important to understand that all dementias are not just Alzheimer's. But anyway, going back to the other blocks underneath, so we look when we evaluate and I evaluate people with a dementia, I want to know why. And it really matters as I'll be speaking about it. Most causes of dementia are these other blocks out there. One, there's something called Lewy body dementia. My mom had Parkinson's dementia. There's what's called frontotemporal dementia, and vascular dementia is really having like multiple strokes. All these are, most of these other ones, including Alzheimer's disease, are called neurodegenerative disorders. And what that means is that the brain cells, the wires, the connections are beginning to disintegrate and break down over time, leading into what we see as these changes in the individual. And Alzheimer's disease, and it's in a bigger box below, is because of all the reasons that can cause dementia, maybe stroke, maybe depression, maybe infection, maybe toxic exposure, maybe multiple strokes, maybe Parkinson's, maybe, of all the change that could cause a dementia, of all them, the most common, the most typical one is Alzheimer's, and it's called Alzheimer's dementia. So Alzheimer's dementia of all the forms is the most common. This slide I threw in because there are tests. These are our tests that we do, and this is an imaging. This is an MRI. So for those that have not seen an MRI, this is called a coronal view. And a coronal view is a cross section of the brain. So if you basically were looking at me, if you can see me on my camera, and if you basically took my face and you went back inside the middle of my head, and I hate to say it's kind of gross, if you cut my brain straight down half the middle, that's exactly what these images are in front of you that you're seeing, these black and black gray images. That's called a coronal section, where the MRI, you're coming straight in and it goes straight down and you're looking right in my brain. The gray, as you're looking at throughout these pictures here, that's what the brain is gray. And the four different brains that you're seeing, the one to the far side, the control, that's a normal person. And in someone with a normal brain, the gray is full. And the black areas, like the black lines and the zigzag lines and that thing right in the middle, say a butterfly a little bit, all that's what a normal brain straight through looks like. But if you go over it, I'll use, here, let me see here, I'll do this. So if you see what I'm doing here, I'm moving my mouse around, this is a brain of someone with Alzheimer's disease. And these black areas here, these are called the ventricles, the water part of the brain. And these here, where I'm circling here, this is part of the brain called the temporal lobe. The reason why it's black, bigger black than it is in a normal brain, the reason is because the gray area of the brain has shrunken. It's shrunken down. And when it's shrunken down, the black areas get larger. And the black areas, that black is actually water. Water fills the gaps and crevices around the brain. So the biggest change that is seen on a brain MRI are those typically with Alzheimer's disease versus like normal people that don't have Alzheimer's. But the brain MRI, as I'm showing you here, these are people that have a more advanced Alzheimer's disease. Typically, when someone gets a brain MRI or a CAT scan, when they're showing early signs of a problem, memory problem, often the MRI could be very, very normal. So the MRI of the brain only helps some regard in terms of the puzzle pieces about trying to evaluate why someone is. And the other parts of the brain are little subtle, more subtle changes in someone with diffuse Lewy body disease. And the other one to the other side is in what's called frontotemporal dementia. And I'm not making you all in the science or researchers or doctors, but the MRI does add some value. It can exclude a stroke. It can exclude brain tumors. It can show the fluid or atrophy. It can do that. But the most important thing is really on this slide. This slide is really how the diagnosis could be black and white as to whether or not someone really has Alzheimer's disease. And what is Alzheimer's disease? Again, what Alzheimer's disease is the shrinkage of the brain in those center areas, and microscopically, which you can't see on a brain MRI, is the buildup of these proteins. And the proteins that are accumulating in the brain of individuals, in particular with Down syndrome, is beta amyloid and another one called tau. And what this busy slide is showing is it's showing what these changes within the brain look like in somebody with Down syndrome. And as I'm describing it, I want you to think about this a bit, is that as somebody with Down syndrome is getting older in their 20s and 30s, they have a huge beginning accumulation of beta amyloid in their brain. And the reason why they have beta amyloid accumulating is because they have an extra chromosome 21 in which this is being produced. So they have the accumulation of beta amyloid. It occurs in the brain at a microscopic level. It can then be seen also in spinal fluid. It can be seen in blood. And as they're getting older, that these changes get more and more over time. And this is before they even have anything wrong with them. They're not having a thinking problem, they're not having memory problems. So a lot of these changes that are happening in somebody with Down syndrome are happening years and years and years before they have any problem. If this is anybody, say, with a general intellectual developmental disability or neurotypical people, it's similar. It's a similar way. It's just that it's not doesn't happen as early. So these changes are that are really reminiscent and causing Alzheimer's. These are all called biomarkers, and the biomarker is a biological measurement of what is causing Alzheimer's disease. I'm going to come back to this. This scan here, this is what you're looking at here with these colors. This is a PET scan, and a PET scan is which is called a positron emission tomography, measures on the special scan the accumulation of amyloid. And the one picture here where it goes where it's like all blue and green looking, that's somebody with Down syndrome who's younger, and that blue and green is normal. That person does not have Alzheimer's disease. That person is younger. They do not have an accumulation of those proteins, amyloid. But now when you go to the middle picture where it's all yellow and orange, what that means is with this test, with this PET scan, they can see that that individual has accumulation on the imaging, all these abnormalities, which is amyloid buildup. And that's comparing to the picture right next to it. That's someone who does not have Down syndrome. That's a normotypical person that has Alzheimer's disease that they develop like later in their life, in their 70s or 80s. And don't they look similar? Yes, because it's the same disease, it's the same condition. So I'm going to focus now on about caring, and I could delve into all these at a lot. So caring management. So again, I'm a physician. I certainly am a neurologist, no doubt. But when someone is developing a change, and certainly we're labeling, we're giving the diagnosis of dementia, what does one do? And this is a slide that really goes point by point to point. What does one do? What do you do? What do I do? What does everyone on the call do when someone is handling, supporting, as you care for that person? So the first bullet point is caring, quote unquote, caring. And guess what? Caring means you're nice, you're sensitive, you're worried. And I know that might like seem silly. Like, of course you're caring for the person, but that I can't say that's for everyone. Is everyone who's supporting that person, do they love the person? They care that person? Do they really believe that this person is very valued? So I really put a lot of effort in saying, you got to care about this person. This is someone that has great value and importance, and they definitely need to be sensitive and empathetic toward them. I'm going to be speaking about medication, including cognitive therapeutic medication to help support the memory loss. I'm going to be talking about when behaviors happen, what we do that. But definitely wellness and health promotion is really important because people that actually are getting older with certain change of decline, that they need to stay well and healthy. Good nutrition, good exercise, good sleep, free from disease, free from pain, health and wellness, and that it's a huge topic that really deserves a lot more attention. I wish I had more time to talk about it. People with dementia, people with Alzheimer's in particular, have a number of health consequences: seizures, sleep apnea, they fall, they may not swallow well, they might have cavity problems. There's a whole host of additional medical problems that people have to be treated or looked at. Unfortunately, these conditions, dementia and Alzheimer in particular, do get worse. And as they get worse over time, they need help in supporting them. And we'll talk about that. Tragically and sadly enough, there's a reality that this is a very vulnerable population into itself. But if someone is also developing a form of dementia like Alzheimer's, there's a higher rate and risk of abuse and neglect. So that's a real personal issue that has to really be looked at to make sure that people are not, abusing or neglecting them, which it certainly is a terrible thing. What is the support needs in terms of financial aspects? What is legal aspects? Who's power of attorney? Who's the medical power of attorney? What kind of decision making is being done, supportive or otherwise? Who's doing that when the person's getting older? Who's really helping them? The issue of palliative, the end of life care are real realities that happen as people are going through their stages. And as people, in particular with Down syndrome, their longevity, once the symptoms of Alzheimer's begin, the average age in people with Down syndrome is they only have probably from the first time they start showing decline, they might even have almost 5 years or just about 5 years until they can die. It's a tragic thing that can happen very quickly. In normotypical population, once symptoms of Alzheimer's happen, it could be like 10 years. But in many times, people with Down syndrome can have a more compressed duration of symptomatology because of the nature of their form of Alzheimer's and Down syndrome. I'm going to be speaking about research opportunities also as an important aspect. All right. I'm a medical doctor. So where do the medical people have? Because again, this is a presentation that is talking about primary care, but also those that also are like me as a specialist. One of the complications that happens quite commonly in those with Down syndrome in particular is called myoclonic epilepsy. And myoclonic or myoclonus is actually a rapid jerk. So if I just jump real quickly and it move real fast, That's basically a form of a seizure. It is a seizure that happens in a decent percent of people at the beginning and throughout the time that they have Alzheimer's with Down syndrome. And other kinds of seizures, such as a grand mal, used to be called grand mal, or generalized seizure can occur. So seizures, and they happen because as the brain is degenerating, breaking down, that's why seizures occur. Behavioral challenges are very common. I'll be speaking about that. Walking problems, perceptual difficulties, falls happen, sleep dysfunction, sleep apnea in particular. A very common problem is vision and hearing loss. Autonomic dysfunction, which would be drops of blood pressure, sweating difficulties, those problems, constipation, diarrhea, and definitely pain can also be problematic inherently within those with dementia, including Alzheimer's. And then medication side effects can happen for anybody, but definitely they can be more in tune to being sensitive to medication and having a bunch of different what are called adverse drug reactions. Behavioral problems are very common in people with dementia. Depression, apathy, anxiety, distressing behaviors of all kinds, catatonia, slowness of their body, psychotic behaviors like hallucinating, delusions can be very common. But also people with Down syndrome and other forms of intellectual developmental disabilities might be changing because they're also reacting to their own internal changes, but they're reacting to the environment around them, and change happens to everybody. Are they in the same group home? What's happening to their parents? What happened to their siblings? What's happening to their friends? What happens to them at work? What happens to their sporting event if they're in sport? What's happening to them, and are they reacting for those changes? Delirium. Actually, I'm going to be giving a presentation. We have another work that we do with our colleagues in Rhode Island and Virginia. We do an echo with them, and I'm going to be speaking soon on delirium. Delirium would be, I'll just use an example, like if someone just drinks heavily and are intoxicated, drugs or they get out of sorts, or have a horrible bad infection, it really makes you mentally and physically out of sorts. Comes on quick. There's sometimes they look good, they look bad from moment to moment to moment, and their blood pressure's up, their blood pressure's down, their heart rate's up, heart rate's down. That's basically delirium. Delirium can occur commonly in people in this fragile state of dementia, and that's a very important thing to watch over. Going back to the behavioral difficulties, they are very common. And this slide really talks about the various percentages of depression and delusions. And you can look at yourself. They're very common. I'll just put it that way. And these are often the most distressing things that happen to the person and those that care for them. The most frequent calls that I most likely get from family members and caregivers is not just because they're forgetful, it's because of this, because it really rises up to the level of, oh my God, they're all over this place, and they're loud and they're wandering. I'm worried about their safety. What do I do? What do I do? What do I do? And they're looking for often a medical solution. Doctor, how can I curb? How can I reduce these various behaviors? And in many cases, these behaviors, once they occur and they're very problematic, they're very not great for the prognosis of that person. They lead to a higher rate of hospitalization and ER visits. They lead to a higher rate of burden or worriness to the caregivers, to the person. They have a higher rate of money and expenses. They have a higher rate of risk of getting even put into long-term care. So behavioral issues into themselves are very common in this population, but also lead to a lot more challenges. But why do these behaviors occur? They're inherent within dementia, but it could be a physical trigger. It could be an emotional trigger. It could be a cognitive trigger. It could be an environmental trigger. So triggers, which are mentioned on the slide, can be from various things. So when people are having these behaviors, it's super, super, super important to almost like step back and say, well, why now? Why then? What is the circumstances? Because if you can see the triggers and understand what the faults are, then that would mean that for you caring for the person with dementia, don't do this or change this. Is it the lighting? Is there environment? Is it the colors? Is it the smells? Is it overstimulation? Is it understimulation? Are they infected, like a medical problem? So really important to understand if you can figure this out. So definitely triggers are really important to think about in someone that has these behavioral changes. When these behaviors occur, if you can find the trigger, well, don't trigger them. But when you can help reduce and mitigate these behaviors, it's pharmacologic versus non-pharmacologic. And this slide talks about what is called the non-pharmacologic. These are things that family members, caregivers, organization, the community, therapists like occupational therapists can do to help soothe, calm, relax individuals. And there's a whole listing of these, and we'll be talking about that. I'm a doctor. So what do doctors do? We give drugs. So when should medication be provided? And medications, I'm going to be speaking about this in the next few slides, is you have to understand exactly what once you remove they're not sick from an infection, you understand there's something you can eliminate. But if it's a pure behavioral issue because they're dementia, you have to really see is a drug even necessary? And it really has to do with the severity of the problem. And what is the behavior? What is the target behavior? Is it depression? Is it anxiety? Is it delusion? Is it hallucination? What is it? And the reason why it's important, it has to do with medication being provided. I'll show that in the next slide. And if you're going to give a medication, you got to start low, work itself up a little bit. And if you're going to give medication to someone, you have to exactly make sure that you're expressing the desire to the individual watching them to know if it's going to have the desired effect or not. Can there be side effects? In the goodness of helping them, are there side effects? And what are some of the potential complications? This is a busy slide. And I'm not trying to make everyone on the call today experts in behavioral management. And this is really to give you a general feeling, I suppose, on what doctors, psychiatrists, and others like myself treat people. So this is a general category of various pills, various medications that are given for people with dementia behaviors. Antipsychotics, which are basically the same exact drugs given to schizophrenics, antidepressants. You've heard of antidepressants, mood stabilizers, medicating to help calm and make the person from going up and down, and mood stabilizers. And on the very bottom are two newer types of medication. One is called Rexulti, which is really in the category of an antipsychotic, and another one called Nudexta, which is for behavior called pseudobulbar palsy. So this is really a listing of different drugs, targeted behaviors, and the various dosing that the doctors use or nurse practitioners use to treat them. And then it has a whole bunch of what's the good news versus bad news, side effects. So it really has to do with, what is the problem, what medication is chosen, when you're given it, you give a small amount, you give it some period, a short amount of time to expect it to work. And if it doesn't work, then you have to know. If it doesn't work, what do I do? What's plan B? What's plan C? Feedback. So definitely feedback is so important. And then also it's these other mitigating factors aside just there's behavioral issues. There's a whole bunch of physical problems that can also add and contribute to the person decline. Pain is very common. Do they have dental pain? Do they have abdominal pain? Do they have any other pain in their body? Arthritic pain, back pain. And in someone who is already cognitively impaired and has a lifelong developmental disability, poorly verbal, nonverbal, and they're having a change of behavior, how do you know they're in pain? So I'm going to, I'll be a little rhetorical with that comment. Do they have disruptive sleep? Do they have a thyroid abnormality? Are there concurrent social, personal difficulties? And I brought up health and wellness. Never forget about ensuring health and wellness is being provided, and then treatment for the medication for behaviors. I'll talk about that, and then caregiver supports, which will go more into our next webinar. So there are medications specifically to help memory. And this is a busy slide that really shows in the middle here, it says Alzheimer's disease. That's what the brain cells look like microscopically, the neurons, the connections. And generally for the last 50 years, being facetious, maybe 30 years, there's prescription medication. One's called Namenda, another one called Aricept. These are prescription medications been around for years and years and years to help affect the release of different neurochemicals that slightly might make the memory better or keep them from getting worse. And this has been out there forever that I've been using now all in generic form, and they basically are marginal at best. And there's very little research in what they've done for this population of IDD and Down syndrome, but often when we're trying to do something, you just try it and see if it works without really knowing for sure, does it really help them? And you just try it and see after a while, are they different? These are all going to progress anyway. Individuals are all going to progress anyway. However, in the last few years, the newest thing, and this is really make a breakthrough, is what's called anti-amyloid therapy. And at the very bottom, there's going back to the PET scan again, we have new medication that came out that are basically intravenous shots that are given specifically for mild and early Alzheimer's disease to basically dissolve and eliminate those bad proteins, the amyloid proteins, to basically really make a difference on the brain scan, but also seem to show a better improvement on reducing the severity of and quickness of the progression of their Alzheimer's. And this is really in research. So the two drugs out there, one's called lecanemab and the other one's called donanemab. These are basically proteins called monoclonal antibodies. They're infusions, a shot given in an infusion center that are given somebody who has biomarker proven Alzheimer's disease, a PET scan proven Alzheimer's disease, and they got to be shown that they have this protein in their brain, and they have to show that they're basically at the very early stages. The problem is that none of these treatments that I'm talking about have ever been shown or done or researched in people with IDD and Down syndrome. And I'm going to come back to that. So also, as someone's progressing, there are going to have the functional social complications. Their ADLs are going to change. Their social environment is very difficult for them. Communication issues will be very inherent. Family caregivers, community-based supports, friends. These are things that will eventually catch up with them, and they need more support. And again, end-of-life care decision-making is hugely, hugely important. I'm a neurologist. So not every neurologist, I'm a neurologist that specializes. So what do you refer? So if you need help aside from the primary care provider, when to refer and why. So one of the referral situations may be trying to say, do they really have Alzheimer's? Do they really have do they have a dementia? If you're not sure, you need to know. And eventually, I'm going to say, if you don't refer, eventually the issue of a dementia will always progress. So eventually, even if it's not clear in the beginning, I hate to say the dust will settle, but the most important thing early on is reversible causes. Do they just need glasses? Do they need a hearing aid? Are they having problems with sleeping? Are they depressed? Things like that are huge. That is everything in the beginning. Reversible causes is everything. Do they need higher level of care, like a specialist, like a neurologist? Do they need and I'm being rhetorical, my comment, do they? And the decision of do they need any of these things really depends on the level of the significance of what you're seeing. And if things are you're able to get support and care by your local provider, the nurse practitioner, primary care doctor, psychologists, social workers, and all that. If you're able to get those kinds of supports, then you're basically plugged in. And we will, and also because we're going to be speaking as you saw about the GUIDE program, where does that fit in? And can a university or center like the GUIDE program, where do they fit in? Is there a referral basis for these individuals that can get support? And that's really for Medicare individuals as what a GUIDE is. Referring to emergency. What happens if some crisis occurs? Should you call 911? Well, definitely if a emergency happens where you're worried that someone is having, like I say, a stroke, if someone is really acting out really badly, if you think they got injured or a danger, then basically you really got to call emergency services. You really do if something really changes. But anything that occurs very abruptly, that's not normal for typical dementia. Dementia over time does have its challenges that we're describing, but it really is not an acute and not an abrupt change. If an abrupt change happens, that's atypical. That's really a concern. So that has to be looked at. And then research opportunities are important. This slide, as I'm getting to the end of my presentation, there are research opportunities now. And so I think it's very important to really think about that. And this is basically for those that have Down syndrome, as there are two main kinds of research opportunities. And a lot of the research opportunities in the United States stem from an organization that our colleagues work with, which is called the Trial Ready Cohort for Down syndrome. And these are looking for people that are interested who have Down syndrome, their families want to hear about this, and they basically almost like put them on a list of if they're available for research. And that's why they call them trial ready. They're getting ready for it. But what would that research be? Because there's this early accumulation of beta amyloid, wouldn't it be something if someone who's in their 20s or 30 years or 40 years old, well before they have difficulties, can they get treatment before they even have problems to melt, dissolve, and prevent the amyloid from coming up? And that's basically what the ABATE trial is. That's one of the trials. The other trials here, it's called the HERO trial and the Latin trial. The HERO trial, the research trial of HERO trial is also similar to that too. Are the therapeutics in people with Down syndrome that can get a treatment before they even begin to show decline? The Latin trial, the last one that I'm going to talk about, is basically for one of these new drugs, these anti-amyloid drugs, also going early on in someone with Down syndrome, and see if using the early usage of one of these monoclonal antibodies early on can really make a difference for them. The guide program, I think for those that have been listening to our NTG webinars, is very important to understand. We do our training, as I was mentioned, for the navigators, those people that are working with these various guide programs to help reach out to families, help support them, give them information. And the NTG, as described, we have training, and this webinar today is part of that training opportunity to work more about that. I wanted to thank everyone. I know I probably talk fast. I have not taken one breath yet. This slide, my last slide, that is a picture of me, and the individual, the person I'm having my arm around, he was a friend of mine, Pete Taylor. That's Pete. That's me and Pete. And Pete and I were together at a social ball, a social event, a part of Bancroft in my area in Southern New Jersey. And it was a social event with other people who were getting support by the organization Bancroft. And it was a bubble machine and music. You know, Pete's looking great. He's got this, like, he's got his corsage in. I know Pete because he was my patient, and I'm speaking about Pete. Sadly enough, Pete, I was seeing him because he had change and decline, which were basically Alzheimer's disease associated with his Down syndrome. Sometime after this photograph, Pete passed away. Pete passed away. He sadly enough, Pete passed away. He would come in all the time with his sister. I got to know them very personally for a long time. And in honor of Pete and many other people who have passed away or are getting older with concerns, and this is an honor for him. So I just wanted to say, hey, Pete, thinking about you, my friend. All right. So thank you all so very much. I will leave a short amount of time for questions. So Natty, Helen, back to you.
Yes, absolutely. Thank you so much, Seth. And we have a number of questions. We got some theme questions going on where several people have asked
Okay.
similar questions. So I'm going to start with those because that's where the latter questions have been. And it
Okay.
really had to do with some of those newer diagnostic um, efforts and early treatment in order to look at plaque reduction or removal, as
Yes.
well
Yes.
as access to PET scans and
Yes.
that type of. So the questions really have to do with for people with intellectual disabilities, accessing insurance coverage and the ability to get into a clinical trial, to get into how would some of our participants in the webinar today be able to bridge their patients or their families that they're working with into some of the trials and the more progressive things that are happening, particularly for
Definitely.
people with Down syndrome who really want to pursue some of this. Yeah.
Well, I think philosophically, this is a very ethical, philosophical, moralistic discussion. It really, let's talk about civil rights. Everyone deserves care, right? Everyone deserves to know what's really wrong with them. And it's not that obvious. It's obvious. It's obvious. And research, if we don't really know the facts and we don't, research, we're never going to know whether these therapeutics are appropriate. So definitely research is huge. And because Down syndrome has such a high rate of prevalence, 60% by age 60, and it goes up and up and up after that, it's almost like a guarantee in some regard to most people with Down syndrome. And therefore, for those that are young with Down syndrome and their families, they needed at some point have a reality. And the research in Down syndrome and Alzheimer's, as I kind of mentioned, is a huge issue. And right now, I know that in the world for Down syndrome, and specifically our friends and colleagues in research, are really out there speaking, beating a drum about trying to get people into these trials. So we do know whether these treatments work. We do want to know if they could be prevented. We want to know if they don't have to have that future of progression leading to dementia, leading to Alzheimer's and death. So we need that. Now, that's for Down syndrome. Now, the other population of intellectual, all the other people, everyone with CP and autism and all the other people, what do we do about those individuals? Well, the reality is, and this is just, I say a harsh reality, is that for them to be in trials is going to be really hard. It's very difficult. What is going to be the most important for anyone who does not have Down syndrome but has a type of an intellectual developmental disability isn't really about research, I would say. It's about recognizing that they're even developing dementia at all. That's really going to be the most important thing because I really do believe in my non-scientific, non-data driven mind about this one. There's a large number of people that many of you on this call might know and care for, and they might even have dementia. You may not even be aware about it. Like one question would be, Joe or Mary, who you know, I'm just making a name here, comparing their functional ability, their ADLs today, and they're older in their 50s, 60s, 70s, are they different? Are they able to do the same thing that they did 5 years ago? And if you say no, then why? Why are they different? If it's not their arthritis, it's not their eyes, it's not their hearing, why can't they work? Why can't they do things? Why can't they act? They might have dementia or Alzheimer's disease and they're happening right in front of you. So I think recognition is the most important thing in this population that doesn't have Down syndrome because I think it's happening all the time because it might be so insidious. It might be so slowly evolving over time that before you know it, they've evolved. But research for Down syndrome, I know, Helen, I'm not quite answering that question, but research opportunity is really important. But recognition overall,
Yeah.
EDSD usage early on, etc., how we detect change is rich, important.
So, Seth, a related question has to do with that issue of diagnosis in
Yeah.
the primary care setting,
Yes.
and that given the to talk a bit more about the availability of real diagnostic tools for people with an intellectual disability to use in the primary care setting.
Well, the tools available, let me just put it this way. The same tools that are available for someone with an intellectual developmental disease, the same tools for by a primary care doctor are the same. There's no difference between the availability between an MRI, blood-based, these blood biomarkers, the PET
Mhm.
scans. There's the only difference basically is the willingness to use to order the tests, the thought that maybe I want it away, they want to order the test, and will it be covered by insurance? So in my role as a neurologist, I look at all these factors. So Medicare in particular mostly covers most costs of the blood-based biomarkers, which are the amyloid and the tau. They cover most of the costs for the PET scans. And in someone with Down syndrome, if you did a blood-based biomarker or a PET scan on them now and they're 40 years old before symptoms, the reality is they're all going to show the problem. So part of it has to do with what would you do with the information. So if you do the blood test, you do the amyloid PET scan, you have to know, do you trust the data? Is the data real? Does it really reflect what you're thinking about? But what would you do about it? So you have to really understand, and this is like part of counseling. Are you going to do it because you want to know why their change is? And if you do know what their changes, say it's Alzheimer's specifically, then what would you do about it? Would I give them treatment? Would I begin my planning? Would I anticipate the problem? So I'm not saying that we should know. I vote for knowing. I vote for knowing, but it's also a matter of for the caregivers and support because sometimes it's a stigma. The issue of having a so-called dementia diagnosis could be like a ball and chain. Like if like any of you on the call now, like would you want to know? I mean, would you personally want to know 5 years before you had dementia at the very beginning, would you want to know and have it out there in your insurance and your life that you had dementia or Alzheimer's disease? Would you want to know? And how would that affect you, good or bad? And I think I say it in that term, would you want to know? Because I think you should want to know, but then it's not always that black and white because sometimes there's negative consequences with testing. There are some challenges sometimes. But definitely the testing can be done and the primary care doctors absolutely right now, this very second, can order these tests. And what the companies are doing, I know we're almost out of time here, these blood-based biomarkers right now are being marketed. I don't know if anyone has called from these pharmaceutical companies. Right now, the companies that make the blood-based biomarkers are actually advertising directly to primary care doctors to encourage them to order these tests now. It's part of their marketing. It's a marketing strategy where they want for them to order it, and then once you show a test, then you got a suspicion they got Alzheimer's disease, and then it goes from there. So this is a reality. This is a
Yeah.
reality that's happening in front of us now.
Um, there is one more question I'd love to, if our audience is willing to hang on for this one, but it really has to do with the relationship between autism and Down syndrome, and knowing that there is an elevated prevalence of autism among people with Down syndrome. Given that, is there, if someone has autism and Down syndrome, would that increase even more the likelihood of development of dementia, or is there no real relationship there?
Well, let me just put it's a great question. It's a really a wonderful question, honestly. I mean, I definitely see a good number of people with autism without Down syndrome. I see a lot of people with Down syndrome that have autistic features. What I think is there's no data, honestly, that I know of that says if you have someone with Down syndrome who's also has autistic features, I'm saying autistic features, you don't really know. I don't really know. I don't really know if it really changes the trajectory, the prevalence, the complications. But because autism is a behavior of some sort, those behaviors in some respect in someone with dementia can change. So it's really how does someone with autism generally change in their behaviors? Autism behavior changes with developing a dementia. And I think that's in itself a very, interesting thing because that's what would happen is sometimes those behaviors of autism behaviors will change. But in Down syndrome in particular, there really, I don't see any or knowledge of any data because they all have a high risk anyway. So I'm not really sure it changes much.
Okay. And one next question, are there, have you seen people with autism? I'm sorry, people with Alzheimer's, are they at higher risk for stroke due to the amyloid plaque deposits in the brain?
Absolutely, that's a great question. What it actually happens is they not only they have a higher risk of stroke, but brain bleeding, and that's actually very relevant to the complications of these treatments, the anti-amyloid treatments. So what happens with these microscopic particles, aside from making the brain cells degenerate and fade away and developing dementia, what happens to those proteins, the amyloid protein, is they circle around some of the blood vessels of the brain, leading to strokes and also what's called amyloid deposition, leading to brain bleeding. So I see not too uncommon in my inpatient population of people that are seen with hemorrhages bleeding in the brain, and and they've already shown maybe some signs of memory loss, or they already have Alzheimer's disease. So there's definitely a correlation. And the treatment, the anti-amyloid treatments, the risk of the complication of the treatment is they cause brain bleeding. So in someone that already has an MRI that shows what we call microhemorrhages, small blood vessels, we know that they're at risk of getting complication with these anti-amyloid drugs. So MRIs are done all the time in people that are before they get an anti-amyloid treatment and afterwards to look for those complications. And people with Down syndrome who've had years and years and years already of early accumulation of beta amyloid, that's a safety issue. And that's kind of why there was a hesitation. It's a great question about me asking this question. That's why there was a great hesitation about why should we just give everybody Down syndrome these anti-amyloid treatments? Aren't they the same like anyone else? They may not be because of that issue of bleeding and complications that might pose more risk and unclear benefits.
Okay, thank you. Um, I want to be able to turn things back to Dr. Rosas to talk a little bit about the CMEs and CEU process. But before I do that, I just want to reassure our audience that we have a record of all of the questions that were asked. And for those that we didn't get to, or that you feel you are looking for a more complete answer on, they are all going to be directed to Dr. Keller, and we will be responding to those to the audience as a whole with the questions and answers in writing within the next week or two. So, and on that, I will turn things back to Dr. Rosas.
You're muted, Natty.
I'm sorry. I couldn't find my unmute button. Okay. So, I shared the links for the CMEs and CEUs on the chat. Very important. Wait. I want to share it again so you'll understand. Okay, here it is, the slide. If you are a nursing professional, okay, so if you have a nurse degree of any kind, please fill out the survey that says DDNA use only nurses. And so again, you can use the QR code. I also posted the link in the chat. So look up in the chat and you will find it. So that is only for nurses, okay? If you're a physician or everybody else, you can fill out the AADMD survey. At the end of the survey, you will get a link to get the CMEs. If you have a nursing certificate, you fill out the survey, and then we will send you what you need to get your CEUs. And I know some of you ask, how do we know that you attended? Because Zoom, if you registered for this webinar, Zoom then gives us a list of those who registered and attended. So that's what we use. And okay, so hopefully that is clear. If you are a nurse or any type of nursing degree, DDNA survey, complete the survey, and we will get you what you need. If you are a physician or you need some other type of certificate, please fill out the physician's AADMD. If you do not need a certificate, when we close this Zoom, you will be directed to fill out a survey, and we do appreciate everything you have to say about the presentation. I think that's all. Catherine, did I miss anything?
No, I think you got it all. And thank you everyone for attending. We had almost 700 people registered, but of course not everyone is in the same time zone or can take the time to do it. So everyone will be getting a link to the recording. If you were registered, you'll get a link to the recording within the next day or two, along with a link to download a copy of the PDF of Dr. Keller's PowerPoint if you have not already done so. That link has been in the chat box several times.
What about our next presentation? Then we have another great talk coming up too.
Yes.
What about that?
Yep, I was just getting there.
I beat you to it.
Yeah,
we got more coming.
May 11. I don't have a calendar in front of me, but I think it's May 11. Does that date sound
May
correct
11th,
to
yes.
everyone? And it is the NTG's own Kathy Service who is here, along with a colleague from McLean Hospital in Massachusetts. And Kathy, do you want to just very, very quickly tell people what that webinar, what you are going to focus on?
Yeah, Marie Clocour, who's a licensed social worker at McLean Hospital, and she's also a navigator for their guide program there. And I'm going to be talking about post-diagnostic supports both for families, for people living with dementia, and for any other care providers, paid or otherwise. So hopefully we're going to be going through a lot of the things that Seth kind of touched on, but go through the whole continuum of it.
Definitely. That's vital information. So please all make sure you're.
And Dr. Roses just put the link to register if you haven't already in the chat box. So if you haven't already registered and you'd like to attend, please click on that link and we'll make sure it goes out again with the post-webinar follow-up from tonight. I think that's it. Any last from anyone?
Thank you all. It was great. We got a great attendance from all over the world. Really wonderful. Thank you all for being here. And thank you for the team. This really took a team effort for all those in the call who helped put this all together. Thank you guys so very much. You did all a great job, and thank you.
And again, for those of you who don't need CMEs or CEUs, once I hit the end button here, or Dr. Roses hits the end button, and we sign off, you are going to get a survey that's going to pop up in another browser window. And if you would just take a couple minutes to give us your feedback, we take it very seriously, and we'd love to hear what you think. So thanks very much, everyone, and have a great rest of your evening or whatever time of day it is, wherever you are on the face of the earth. Thanks, everybody.
Night, everybody. Thank you.